So now I have the pleasure of introducing Dr. Carmen Bergom, who is a radiation oncologist from Washington University. She's associate professor in the Department of Radiation Oncology there, and she's really interested in improving cancer treatment efficacy and minimizing side effects for cancer patients. Her research program is focused on ways to improve the efficacy of radiation therapy in breast cancer while minimizing side effects, most notably cancer or cardiotoxicity. So welcome, and she's going to come up and give the next talk. Her talk is titled Radiation Therapy and Cardiovascular Disease in Breast Cancer.
Thank you very much. It's great to see so many people at this session. Just trying to advance these. There we go. All right, these are my disclosures. And so just to give a little bit of background about radiation-induced cardiotoxicity, as you know, there are over 250,000 breast cancer patients diagnosed in the US each year, and radiation therapy is received by a little over half of all breast cancer patients. Radiation can improve breast cancer-specific survival, but heart radiation can cause long-term toxicity. And as Susan nicely outlined in the last talk, many patients are already at high risk of heart disease due to comorbidities, may have heart disease already, and/or receive cardiotoxic systemic therapy. So when we add in radiation and they receive some heart exposure, it's something we really need to pay attention to. Radiation-induced cardiotoxicity is a complex constellation of dysfunction. It includes pericardial disease, vascular disease, conduction abnormalities, coronary artery disease, myocardial fibrosis, or valvular dysfunction. So it makes it challenging to track some of these toxicities and look at its association because it can be multifactorial in its manifestations. And it's caused by a number of different dysfunctions that can occur immediately at the time of radiation, but also secondary effects that can be months to years. And as clinicians, there are a number of things that we can control as radiation oncologists for our patients, but we need to take into account these things when we plan their therapies. And unfortunately, biomarkers and preventative therapies are lacking for radiation-induced heart toxicity. And so this just shows schematically, once again, the kind of abnormalities that can occur. And these changes most often occur as late effects, so typically years later in breast cancer patients. And so, as I mentioned, this can be challenging, and one of the reasons that it's difficult to get great data about some of these, and I'm going to highlight at the end the importance of putting some of these cardiovascular outcomes into our studies that include radiation to better advance what we know about this constellation of cardiac dysfunction. So there's been an increase in radiation-induced heart dysfunction. Really, this started in 2013 when Dr. Darby published this landmark paper in the New England Journal of Medicine. And in this paper, she demonstrated that data showed that the mean heart dose of radiation was associated linearly with major coronary events, and the risk was about 7% per gray. And since that time, in the 9 years since that publication, there has been more than 24-fold increase in publications in this area. So it's really led to an influx of research in what we know, but there still is a ways to go. So what I'm going to highlight in the rest of the time here is some of the risk factors we know of and newer techniques that can minimize cardiac doses, which of course is our goal is to get the heart dose as low as possible. Some data on cardiac substructure doses and dose constraints that can help us as radiation oncologists to plan radiation for patients. And then also some newer guidelines that tell us that we should be looking at coronary artery calcifications in our planning scans in order to better stratify risk. And then a little bit of data on some emerging data on cardiac imaging that may help us to better identify early dysfunction in radiation patients, and then once again highlight guidelines and surveillance for patients who have radiation-induced cardiac exposure. So as I mentioned, the Darby paper looked at the association of mean heart dose with major coronary events, and other papers have also shown that there's a linear relationship. And importantly, they show that there's no threshold below which there was no risk. So even as techniques improve and the doses that received by the heart get lower, these patients still have a risk of cardiovascular side effects, and so we need to still pay attention to this. The cumulative risk of cardiac side effects is also related to underlying cardiac risk factors. So the data we have is that risk factors such as smoking, hypertension, diabetes, coronary artery calcifications, all of those can help us to stratify patients at highest risk and maybe use more advanced techniques in certain patients who are at especially high risk. For example, these could be techniques such as proton therapy, which you may need to get special approval for and things like that. So in addition, the presence of cardiovascular risk factors was found to double the risk of major coronary events in another study. And the baseline risk of ischemic heart disease was six-fold higher, gave you a six-fold higher risk of a future event after radiation exposure. In a large study of more than 4,000 breast cancer patients with over 18 years of follow-up, the presence of both being a smoker and having received radiation tripled the risk of myocardial infarction versus those patients who were non-smokers and did not have radiation exposure. So, as I mentioned, radiation techniques have greatly improved over the decades since the 1990s. And this has gone from two-dimensional to three-dimensional treatment. So with two-dimensional treatment, we didn't know the dose to the heart. It wasn't something that we were actively trying to decrease. But with three-dimensional treatment, it was CT-based planning. We can see the heart, we trace out the heart, we track doses, and we try to minimize it as much as possible. In addition, there are more advanced techniques that allow us to, in certain patients, decrease the heart risk even more. So in certain patients, we might use prone positioning versus supine positioning. We can use deep inspiration breath hold or gating, and at times, advanced techniques such as protons could be used. This is just showing one example of one of these techniques. This is something called deep inspiration breath hold. It makes use of anatomy whereby when most patients take a large breath, the lungs expand, the heart moves posteriorly and inferiorly, essentially moving away from where the radiation beams are going. And this is shown on the right here, where you can look in the same levels of axial slices with free breathing versus DIBH. And just anterior to the red line is where the breast beams would be treating. And you can see that in these inferior axial slices that the beam would actually be going through the heart, but with deep inspiration breath hold, it would not be. So, Dr. Taylor had a series of papers where she compared mean heart doses over the decades, so it's nice to look at these. But in the 1970s, it's estimated that the mean heart dose in the average breast tangential plan was over 13 gray. 2006, it was 2.3 gray, and it's probably even lower in the 2010s and beyond to the present day. And likewise, different analyses looking at cardiac toxicity in left versus right-sided patients over the decades. These differences have diminished greatly as we go forward in time, where they may not be evident in some of these studies where we're not controlling for other variables. However, this is still a problem. As I mentioned, there's no threshold below which there is no risk. And so this is a recent paper published last year on the WeCare study, in which they looked at the risk of coronary artery disease in over 900 patients aged less than 55 who received radiation for breast cancer. And the median follow-up was 14 years. They excluded those who had coronary artery disease at baseline. And what they found is that the cumulative incidence of coronary artery disease for patients receiving left versus right-sided breast cancer was about twice that, and left-sided versus right-sided at 27 years, so 10% versus 6%. So it still is an important problem, and what can we do as clinicians to minimize this and to better treat the patients post-treatment? So beyond mean heart dose, which is what we've been talking to up until now, which is the average dose received by the heart, there aren't well-established cardiac dose constraints for cardiac substructures or different regions of the heart. So that's one of our clinical challenges. And as I mentioned, we also don't have biomarkers or genetic markers where we could stratify patients up front to know whether they're at higher risk or lower risk. And those are areas of active research in my lab and many others. In addition, surveillance imaging and biomarkers aren't well established. We do have guidelines and consensus statements, but a lot of them don't have high-level evidence to back them up, so that's needed as well. So as far as cardiac dose constraints, research cooperative groups had a threshold between 3 to 5 gray for mean heart dose to consider a plan acceptable. These studies such as NSABP B51 and the Alliance A221505 trial. And the question is mean heart dose the best constraint to use? So if you think about it, there could be two patients with very similar mean heart doses that have vastly different volumes that receive higher doses versus lower doses. This is especially true in patients who receive a specialized type of radiation called intensity modulated radiation, which is with a number of small beamlets. And what tends to happen in those patients is they have large areas of the heart getting low doses of radiation, but very small areas that get higher doses of radiation. And so you would imagine that maybe these risks might be different in these patients. And we don't have great data on that at this point. But this is showing that more and more studies are now examining whether there might be better metrics to look at to quantify risk of cardiac events or survival in certain regions of the heart versus the whole heart doses. And this was from a recent review last year. And if you look, the studies in blue are those breast cancer studies. And so these are focusing on dose to the left ventricle, especially in the LAD, and found that doses received by these areas might be better predictors of outcomes than whole heart doses. And this study highlighted here found that the dose to the left ventricle better predicted cardiac outcomes than mean heart dose. And actually in that paper, it's a very nice paper, has formulas for long-term cardiac risks based on the left ventricular dose, age, and cardiac risk factors. So that can be helpful for clinicians. And this and other work have led to suggestions for dose volume constraints for the left ventricle and the LAD. And recently, or within the last few years, the German Society for Radiation Oncology Breast Working Group have recommended some constraints. I'm not going to go through them in detail, but they do provide some constraints for the left ventricle and the LAD in addition to the mean heart dose. And these can be hard to achieve in all patients. I've found, especially those that receive regional nodal irradiation, but it's definitely a starting point, and I think it's important to start to look at that. Of course, if we're going to measure dose to different cardiac substructures, we have to contour them. And so it can be difficult with non-contrast CTs to contour out these different areas of the heart, but there's a number of atlases that are published and available. And in addition, auto-segmentation methods have been published by a number of groups. And hopefully in the not so distant future, these kind of auto-segmentation will be implemented and put into our planning software so that this could be done on every patient, because it is quite labor intensive to do all of this on each patient. So this is just showing an example of one such program. And so importantly, after radiation, survivorship care, actually at the start of diagnosis, during radiation, and after radiation, how do we best follow these patients and care for them? So I think this is a recent published consensus statement from the International Cardio-Oncology Society. And what I wanted to highlight here is that they do mention reviewing available CT imaging for coronary artery calcifications. And I wanted to highlight this because it's something that we can start doing tomorrow in our plans, and it can help our patients. So coronary artery calcifications, or CACS, can be seen on non-contrast CT, and they're a direct measure of atherosclerotic burden. And in fact, they're the best predictor of future cardiovascular events in the general population. And CACS on radiation planning or cancer surveillance CTs correlate with more formal CAC assessments. However, there could be false negatives because of the slice thicknesses and lack of cardiac gating. So they're not necessarily as sensitive, but if you see the calcifications, that should represent a true calcification. So, studies have found that CACs pre-radiation are independently associated with cardiac events after breast radiation, even after adjusting for mean heart dose. So this CAC assessment on radiation planning and follow-up scans can identify patients at highest risk of cardiac events. And as soon as I saw this data, I've started to notice this in my patients. And if you're contouring out the heart and contouring out the LAD, if you see these calcifications, I make sure that this patient has a cardiologist or gets sent to cardio-oncology, and I pay extra special attention, to, is there anything more I can do to spare the heart? And sometimes that is that, you're always heart versus lung doses and things like that, you have to make compromises. But these are the kind of things that can help stratify and best treat the patient. And so as far as imaging recommendations, as I mentioned, there isn't great high-level data on this, but the consensus studies do recommend in those at highest risk within 1 year to get at least an echocardiogram. And then for those who are at lower risk, at least every 5 years to get imaging, cardiac imaging. However, strain imaging and regional assessment of dysfunction may be more sensitive. And so there's just some data coming out about that, and I wanted to highlight one study very quickly about that. An example of regional imaging studies is this study by Trivedi et al. In over 60 patients who received left-sided radiation, and at baseline, 6 week and 12 months, they had echo strain imaging performed, and they correlated changes regionally in the left ventricle with the dose received in those areas. And this is shown schematically, or this is shown in this figure where they had cumulative data from all the patients overlaid on these regions of the left ventricle. And what you can see, the areas of best strain are orange. So this is at baseline, 6 weeks and 12 months. And this is also down here, it's the, this is showing the dose received by patients. And this is the differences in strain. So the higher, the darker red color, it shows greatest decrease in strain at 6 weeks and at 12 months. So what we see is that the largest decreases in strain were seen in the areas with the highest dose. And so if we do more and more studies, this kind of imaging might be more helpful for breast cancer patients. The caveat to these studies is we don't know how this correlates with true clinical symptoms and clinical dysfunction. And so with that, I just wanted to make sure that we highlight how important it is to to put cardiac endpoints into our studies. And this is a very nice analysis looking at phase 2 and 3 trials from 2006 to 2021 in the pre and post-Darby era in breast cancer. And what we see is that the amount of studies including these endpoints has improved, but it's still, we have a long way to go. And so I would like to highlight that. And so with that, I wanted to conclude and just highlight how clinical data demonstrates radiation-induced heart disease is an important clinical problem. We have less cardiac exposure over time, but there still is exposure and patients are still at risk. And that radiation doses to heart regions can be important beyond the mean heart dose. And it's important to examine coronary artery calcifications on CTs to assist with risk stratification, and note that consensus guidelines are available for cardiovascular follow-up. And more prospective data is needed. And so with that, we aren't going to ask questions now. We're going to hold it for the end, but I wanted to thank you all for your attention.